had we not been as aggressive in assuring a continued revenue stream, are there specific examples of things you can think of that might have occurred that would actually put us on a more efficient future trajectory for healthcare? And let me just add a dimension to this. It's already a hard enough question, so I'll make it even harder, which reflects some of the questions that have come in from the audience. You know, the national health expenditures and those accounts are all aggregated, but they're huge distributional differences: rural, urban, teaching, non-teaching, hospitals, doctors, pharmacy. And so another dimension of the question about all of what all the resources we plowed into the sector is whether there are parts of the health system where you think a little more financial pressure might have actually led them to do some things that would be efficiency promoting in the long run, or are there sectors where you say, even though we plowed a bunch of money and it wasn't enough and they're still not going to make it? That's a lot of different questions wrapped in one, but love to hear your thoughts on any of those.
I think it's Kate's turn to give the answer.
I think it is.
Yeah,
that's a great answer.
David's kicking it back to me in the hard one. Okay. Let's see. I'll start by saying I don't know and yes and no. But let me put a little more structure on that. I do think that I think it would be hard to look at the payments we made to healthcare providers during the early stages of the pandemic and say that that was optimal. I think it's actually hard to make a bunch of optimal decisions in a pandemic that you have not experienced and before, certainly in this type of healthcare system that we have. So I'm not pointing fingers and saying people did a bad job. I'm saying, oh, if we'd had like 6 months to a year to think about this, maybe we would have made some slightly different decisions. Okay, but to get more at the heart of your question, Alan, what could a different set of decisions have looked like? I think one of the key questions is, if we made a different set of payments, could we have structured a set of payments that effectively targeted low productivity providers and preserved high productivity providers, right? So that seems like an important question to me. If we were, maybe things were overly generous and poorly targeted, but could we have, squeezed in ways where, we could have driven, different types of, exits from the healthcare industry and supported folks that were more, more highly productive providers, for lack of a better words, right? So could we have pushed on the least efficient providers in the healthcare system? Maybe, but that's what I kind of would have wanted to see. I think the other issue is, even if we had done that, right, and we, could have, kind of reallocated things optimally, I think we still would have had to change incentives going forward, right? So it wasn't just a matter of, can we, funnel money to the places where it's most needed right now? It's, could we have pushed harder on moving to different types of payments incentives for all providers, right? And then there's an interaction of those two things, right? Like, if we had pushed the providers who were the least efficient under this the current way we structure our healthcare financing, those might not be the providers who are the least efficient under our kind of new system of healthcare financing. That's, somehow we were able to create out of the crisis that we had at our hands. So I think that's a yes, no, I don't know, but there are some thoughts right on those issues.
That's great. Thanks.
Let me say, first off, it's my general policy to agree with everything Kate says. So let me just a couple of points to add. One is, I think a pandemic is not the right time to ask for a lot of change beyond just treating people, right? So, you're sort of worried about life and death matters and how do we keep people healthy and so on. And there's, attention is a finite resource. And so I for one, was not, as I've been as big on pushing providers to change as any human being could be, I think. And even, and I, during the pandemic was like, okay, you have to lay off a bit because these people are working 20 hours a day, 25 hours a day, just trying to keep people alive. And so you have to accept that. To the extent we make a mistake, I think it would be not in not following up from the pandemic, which we're still figuring out how we're going to follow up. But it would be that more than not pushing even more change during the middle of the pandemic. One thing that is almost certainly going to happen is there will be more consolidation as a result. Small provider practices will want to merge with bigger folks because they're going to say, okay, my revenue base is no longer as steady as I thought it was. And, I don't want to be in the business of laying off my staff whenever there's a pandemic, and it looks like there's going to be more pandemics and so on. And even some bigger provider groups with a big physical space are going to want to condense their physical space and stuff like that. So I sort of think that now is the time to come back and say, okay, as it's easing, we need to transition. Of course, the problem is it's not easing uniformly. We still have that staff shortage, which is preoccupying everybody. But that may be the impetus to do things. That is, look, we can't hire enough workers. Many of them have probably permanently left the industry. It's going to take a while to train more. How about we put in place things that don't require as many workers? The obvious one, which I've written about some, is administrative costs. Like, if you're going to get rid of some workers, get rid of the ones doing administrative costs for which you don't need them to be done. And by the way, those are just incredibly talented people who can do a lot of other valuable things in healthcare, outside of healthcare too. So I think of it sort of as like, okay, the pandemic taught us stuff, and now we need to keep going with it. Just on a different dimension, when I've spoken to a number of public health officials and so on, what they say is a kind of similar thing, which is everyone has realized during the pandemic that marginalized communities got hit more than better off communities. Now's our chance to, of course, we recognize that's true all the time. And now's our chance to turn that into something that looks like a stronger platform to address social determinants of health and other kinds of society-wide issues affecting health. And so again, that's another example where the pandemic alerts you to things that maybe you can keep the progress going and say, okay, now we need to change it. It's what's interesting to me is relative to the height of the pandemic. Say, if you look at telemedicine visits have declined some, but not back to where they were. So there seems to be a permanent part, which is telemedicine. Not that that's going to save the world, but just that's a kind of indicator of what's going on, where there's been, it's not used as highly as it was, but it's not like it's gone back. And so there are some ways, I think, in which the health system understands that there will be permanent changes that result from this and is open to saying, how do we build on those?